The care of the postpartum patient is covered in chapters 12 through 17 and is split into two lectures. Chapter 12 covers the physiological assessment and nursing care of the postpartum patient. The postpartum period is defined as the 6 weeks after delivery or birth, and any patient who is at increased risk in the antepartum period, mother or baby, is also at increased risk in the postpartum period. Therefore, the focus of the postpartum nursing care is really to assess for early signs and symptoms of potential complications and to treat or intervene as soon as possible. We want to provide comfort and aid in restoring physiologic functions to baseline. And appropriate comfort measures would be ice, sitz baths, peri-bottles, heat to the abdomen for after pains, ibuprofen or Toradol for mild to moderate pain, opiates as needed for severe pain, witch hazel or Tux pads for hemorrhoids, and then distraction and positioning as non-pharmacological interventions. Health promotion and family education are also critical during this time frame to help the family transition into the postpartum phase. The postpartum client is at risk for hemorrhage and infection, and so the body systems that we're specifically concerned about are the uterus, the endometrial lining, the vagina, the perineum, the breast, and the urinary tract. We assess the fundus, the lochia, and vital signs 15 minutes for the first hour, every 30 minutes for the second hour, and then every 4 hours for the next 22 hours, and then every shift or as needed after the first day. To ensure you find the signs and symptoms of hemorrhage or infection early, you should first wash your hands, introduce yourself, and explain what you're going to be checking. Have the patient void if they don't have a Foley in place. Position them supine on the bed and flat. Support the lower uterine segment with one hand while you palpate the fundus with the other hand to determine the location, which would be the height in relationship to the umbilicus, the position, which would be midline or displaced, and the tone, which would be firm or boggy. You want to check the perineum for Rita, which was redness, edema, ecchymosis, discharge, and approximation of wound edges, and then the lochial flow. And check the breasts for any engorgement, redness, or pain. The uterus goes through a process of what's called involution, where it returns to its pre-pregnancy size, shape, and location as the placental site heals. A boggy uterus is the highest risk for hemorrhage, and it's called atony, or uterine atony, which is that the muscle has relaxed and therefore it's not clamping down on those blood vessels and it's going to bleed. Massage the fundus with the palm of your hand in a circular motion and then reevaluate within 30 minutes if you notice a boggy uterus. Give oxytocin to contract the uterus. You can give 10 units IM or between 10 and 40 units in a liter bag IV, and you want to notify the provider right away if massage does not correct the bogginess. A deviated uterus would indicate that the bladder is distended. If the patient cannot void, you want to place a Foley catheter immediately to prevent uterine atony and hemorrhage. After pains are normal, especially if the patient has had prior pregnancies and deliveries, or if she is breastfeeding. And postpartum uterine contractions may be painful, so again, using heat on the abdomen can help with some of those pains. Immediately after delivery, you should be able to palpate the fundus about halfway between the umbilicus and the pubic symphysis. By 6 to 12 hours postpartum, the fundus will return to about the level of the umbilicus or even slightly above. By day 1, the fundus should be firm and the location should be roughly U-1. By day 2, it should be U-2, and so on. So every day it decreases by about another finger width or centimeter. When you're assessing lochia or flow, you want to, again, look at the pad, look at the amount in 1 hour, and then also color and odor. Postpartum hemorrhage risk is greatest in the first hour, so make sure that you're assessing the pad frequently every 15 minutes in that first hour. Scant bleeding or scant discharge would be 1 to 2 inches or with wiping. Light is 2 to 4 inch discharge on the pad. Moderate 4 to 6, and heavy would be saturated. Remember, with clots, 1 gram is the same as 1 milliliter of blood loss. Small clots are okay, but large clots should be weighed and reported. You want to document the color. For the first 1 to 3 days, it will be rubra, which is red. For 4 to 10 days, it will be serosa, which is a pink-brown color, meaning that's kind of an older blood. And then after 10 days, it turns to alba, which is a yellow-white discharge. It's super important that we teach moms the signs and symptoms of postpartum hemorrhage because of the risk of late postpartum hemorrhage that can happen even up to 2 weeks postpartum. And endometritis is an infection of the endometrial lining, which would cause foul-smelling discharge, brown or even green or yellow discolored, along with severe pain and fever. The vagina and the perineum should be checked at the time of delivery, and then with each shift, and you want to look for, again, redness, edema, ecchymosis, discharge, and approximation of the wound edges. Assess side lying, so from behind, and assess the pad and the rectum at the same time. Teach the patient how to use a peri bottle, the importance of doing hand hygiene prior to toileting and then after as well, and the importance of changing the pad frequently to avoid infections. For breasts, we want to provide education about engorgement. Engorgement usually happens within 2 to 3 days after birth. If the mother is breastfeeding, she should pump and then feed, so pump to soften the breast and then feed the baby. If she's not breastfeeding, you want to use some sort of supportive or restrictive bra, and then ice and pain medications. We should be checking the breasts frequently to make sure that the breasts themselves aren't showing any sign of mastitis, and that the nipples are not cracked, and that the ducts are not plugged. Colostrum is usually first to come in for the milk. It's a clear yellowish fluid, and it's full of immunoglobulins, IgG, IgA, and proteins that gives the baby what it needs immediately. And then as the milk comes in, it will contain more fats and carbohydrates. Teach the mom about a plugged duct, which is a painful lump, and there's usually no redness of the tissue with a plugged duct. You want the mom to stand under a warm shower, massage toward the nipple to help break up the basically calcification and allow the milk to flow. You want the baby to continue to nurse on that breast with the chin pointed toward the obstruction. And you can continue to pump on that breast as well, and it's a good idea for mom to fully drain the breast. So if the baby falls asleep while nursing, the breast should be fully drained. Warm compresses also help if mom can't get into the shower. Mastitis occurs usually within 3 to 4 weeks after birth, mostly for breastfeeding moms. And you notice an area of redness that's also warm. Mom usually has a headache and flu-like signs and symptoms. Unilateral breast pain. Oftentimes moms come in feeling like they have the flu or like a sinus infection or something else, and they don't even realize that they have something wrong with the breast. Keflex, which is an oral antibiotic, is very effective in treating mastitis. And then meticulous breast care, analgesics, rest, and hydration. It is okay for the baby to breastfeed during mastitis. The exception to that would be if there's an abscess that is open and draining pus where the baby would get it into their mouth, then you want to pump and dump. So with an abscess, you actually have reached a point where there's a pocket of pus that can be indeed, so it can be incised and drained and packed with like wicking packing, or just opened and allowed to drain and then covered with a bandage. Again, antibiotics, analgesics, rest, hydration, and in that case, skin and wound care. Just make sure that you don't feed the baby the pus is the big thing with abscess. Other things that women are at risk for in the postpartum phase: DVTs, PEs, and orthostatic hypotension. So cardiovascular status, assess vital signs with the lochia and the fundus. So every 15 minutes for an hour, 30 minutes for the second hour, and then every 4 hours for the rest of that day, then every shift after that. Maternal chills are really common in the postpartum period because there's a lot of vascular instability and a lot of fluid shifts. So check a temp to be sure that they're not getting febrile. Slight elevation in the first 24 hours is normal, but a fever of 100.5 or greater is not, and that could indicate a postpartum infection, and you'd want to notify the physician or the provider. Teach mom to dangle the legs before getting up and changing positions slowly, using TED stockings, and monitor vital signs before you let mom pop out of bed the first time or the first couple times, just to make sure she's doing okay. Assess the lower legs for calf tenderness, asymmetry, redness, warmth, and edema. Respiratory-wise, moms are at risk for congestive heart failure, pulmonary edema, and fluid volume overload, secondary to the use of oxytocin, magnesium, and IV fluids. So it's important to assess lung sounds, respiratory rate, depth, and effort. The immune system is also kind of hypercharged at this point in time. We check a rubella status on mom to make sure that she has been vaccinated and protected. We also check an RH factor. So if mom is RH negative and baby is RH positive, we do a Coombs test to screen the RH mom for antibodies, the RH negative mom for antibodies, and then we would give RhoGAM to prevent fetal demise in subsequent pregnancies. Teach mom again, rest, hydration, and explain the importance of vaccinations. With the urinary system, mom's at risk for bladder distension and retention and cystitis, which is inflammation and/or infection. We want to measure each void. The first void must be within 6 hours of delivery. If it's less than 150 milliliters, assess for distension and retention, because uterine atony can cause a boggy displaced, or can be, a boggy displaced uterus can be caused by retention. And then Foley catheters, and we're pretty liberal with Foley catheters on labor and delivery, much more so than any other unit of the hospital. So if there's trauma or edema to the urethra, put in a catheter to avoid retention. Check for post-void residuals, and then teach the signs and symptoms of urinary tract infection. Prevention, again, hydration, don't hold your urine, wash your hands, and the importance of reporting any signs or symptoms. With endocrine, you want to teach them about changes in estrogen, progesterone, and prolactin. So the hormones of ovulation and menses are impacted by breastfeeding. Ovulation, though, can occur prior to the first menses, And so pregnancy is possible prior to resuming menses. It's important that mom talks to the provider about contraception before she resumes intercourse. Diaphoresis is really normal. Again, it's normal for mom to have chills and also just to have like lots and lots of sweating. And that's how we get rid of that fluid that was in the third space, that edema. So again, if you've got a sweaty patient, check a temp and make sure that they don't have a fever. And look for and teach the signs and symptoms of infection. And again, teach the importance of contraception because you know, you're going to need it before you resume any sexual activity. For the musculoskeletal and neurosystems, the patient is at risk for pain. So assess the abdominal muscles, distal CSMTs, delay ambulation until normal motor sensory function returns, especially if the patient had had an epidural or a morphine spinal. A diastasis recti is a separation of the rectus abdominis wall and can change the strength and ability of the abdominal muscles. Headache is not uncommon due to fluid, a spinal puncture for an epidural or morphine spinal and blood pressure issues. And then fatigue also is very common. It's important for moms to be able to rest and to sleep and to be well nourished and hydrated. Depression and suicidal ideation and homicidal ideation should be screened for because these are serious complications in the postpartum period. And then teach mom comfort measures for sore muscles and for sleep. The GI tract is at risk for constipation and decreased GI motility. This usually resolves within about 2 weeks. You do want to check bowel sounds every shift and make sure that they're taking adequate PO fluids and food prior to discharge. We want to teach mom the importance of fluid and fiber and then ambulation for normal bowel movements and proper hemorrhoid management for postpartum care. In our book, there's a great review of discharge teaching topics on page 322 that talks about the signs and symptoms of complications and health promotion topics such as weight, smoking cessation, and contraception. Focus on the signs and symptoms, what to report and when to return, and make sure that anything that's critical gets covered at a point in time where mom is ready to receive the education, where she's at a point where she can actually learn. Provide both written and verbal instructions and make sure she has time to ask questions. Chapter 13 discusses the transition to parenthood. And this is basically changing from the role of being an expectant family to actually being a 3-person or more person family. The majority of learning the parental role and the expectations and responsibilities comes through observing others in that role, and so that's usually either your own parents or people that you would consider role models. And so a lot of times what we consider to be acceptable behaviors is based on how we were parented. The nursing role in this phase is to provide support and education and to be culturally competent or sensitive. Make sure you include the father and the family in the teaching. And your book talks about 3 phases during this transition. The first is the taking in phase, where the mother is very focused inward and at that point in time is really focused on herself and thinking about and processing and talking about her birth and pregnancy experience. During the taking hold phase, mom's very focused on the baby, and this is the point in time where mom is ready to learn and is very teachable. So unfortunately, if this phase does not occur until after 24 hours, until after mom has been discharged, then we're going to need to rely on visiting nurse or primary care visits to provide a lot of that education that mom just wasn't ready to hear initially. And so then after the first few weeks where, mom is pretty nervous about being a new mom, or dad is pretty nervous about being a new dad, there's the letting go phase where they start to really recognize themselves as parents. And once that occurs, they've actually transitioned and really feel like they have become parents. Bonding, attachment, communication, and entrainment are also discussed in this chapter. Bonding is the parent love for the newborn. It's single direction. It's where the parent kind of falls in love with the newborn. So bonding occurs when the parents start to call the baby by name. They cuddle the baby. They talk and sing to the baby. They kiss the baby. They breastfeed or cuddle or hold the baby close while they're feeding the baby. These are the actions that they do that are very kind of like a unidirectional, but they're doing things that are basically in their brain, bonding themselves to that child. Attachment is a bidirectional form of communication. And so like the infant cries and the parents respond, or the parents make noises or comfort the infant, and the infant has a change in behavior based on the parental activities. And then, so there's like a kind of a back and forth between them where they start to learn the cues of each other, basically. Communication between the two includes infants crying and cooing, making faces, kind of tracking objects, recognizing smells. Infants like being cuddled. Entrainment is where they move the arms and legs kind of in rhythm or at the same cadence with the speech pattern of the person who is talking to them. So if their parent is holding them and singing or talking to them or reading a book, their arms and legs will move in rhythm with the speech of the adult. So what we do is try to teach the parents how to interpret and respond to the cues that their child is giving them and how to soothe their baby. Chapter 14 discusses high-risk postpartum nursing care. And so these are the things that can occur in the postpartum phase that have the risk of like serious complication, even mortality. So postpartum hemorrhage is probably the most common thing that we'll see. These complications, they're rare, but because they're potentially life-threatening, these are the most critical things that you should like prepare yourself for. And obviously something that's really high risk but low volume becomes the things that like the NCLEX and they want to ask you questions about, because these are the things that you have to recognize so that you can be safe about. So how do we reduce the risk of postpartum complications? So the first thing we do is review the records. So we want to look for things like anemia, long labors, operative vaginal deliveries, things that would tell us that there's potentially a problem. We want to assess for signs and symptoms of postpartum complications and then intervene as soon as possible. Assist with ambulation to facilitate drainage, prevent overdistended bladder, like atony and cystitis, and then perform good hand hygiene and teach health measures, diets, fluids, activity, and rest so that the person can be as healthy as possible. With postpartum hemorrhage, there are a lot of underlying conditions that can really increase the risk. And those are things like macrosomia, so a large baby, polyhydramnios, so extra fluid, so things that stretch out the uterus, high parity, so multiple pregnancies and deliveries, a history of postpartum hemorrhage, operative vaginal delivery, which would cause direct trauma, augmented or induced labor, which means that that it could have either been a precipitous, like kind of rushed or forced birth that could have caused extra trauma, or it could mean that the uterus isn't really good at contracting and needed assistance, which means that post-delivery it may not contract very well to stop bleeding. Ineffective uterine contractions, so a prolonged first or second stage, again, not a really effective contracting uterus. Precipitous labor or birth, which again could cause trauma. Chorioamnionitis, which is an infection which would lead to increased vascularity and bleeding. Maternal obesity, which changes and alters blood flow and healing. And then coagulopathies, such as coagulation disorders, that would put us at increased risk for hemorrhage. So basically what we're looking at is too much stretch of the uterus, poor contracting of the uterus, precipitous delivery that would cause trauma to the uterus or cervix or vagina, or any sort of instrumentation inserted into the female genitalia that also could have done trauma, and then infection or underlying medical problems. So postpartum hemorrhage is defined as greater than 500 milliliter estimated blood loss if it's a vaginal delivery, or 1,000 milliliters for C-section, with a 10% drop in their H&H. The primary thing that we see that causes this would be uterine atony, retained placental fragments, or lower genital tract lacerations. It occurs in about 10% of all births, and what we see essentially is hypovolemic shock due to hemorrhage. In early postpartum hemorrhage, which occurs within 24 hours of birth, it's usually caused by uterine atony, but also could be lacerations or hematomas. In late postpartum hemorrhage, which starts after 24 hours and can go all the way up to 2 weeks, it's usually hematomas, subinvolution, or retained placental parts. So uterine atony occurs when the uterus is boggy, which causes heavy lochia and signs and symptoms of hypovolemia. Again, we go in and do our assessment, we introduce ourselves, we wash our hands, we tell them while we're there, we have the person void, we check the fundus, and we find that the fundus is boggy, displaced. We're going to massage the fundus, reassess within 30 minutes while we're supporting the lower uterine segment the entire time, have mom breastfeed or do nipple stimulation if she can, and we'll have IV access and fluids running at the same time anyway. And then if that doesn't work, we're going to notify the provider and start oxytocin or Methergin or carboprost, depending on the orders of the facility that we're in. If none of that works, the provider can try by manual compression, where they insert a gloved hand up into the uterus and then push from the outside, or they can pack the uterus with gauze, or they can even insert a balloon into the uterus and inflate it, which causes essentially like a tamponade from the inside. So we're limited to external fundal massage and meds, and then the provider would be above and beyond that. And that's why if the massage doesn't work, you want to call them right away so that they can get there and they can get ready. Lacerations of the cervix, the vagina, the labia, or the perineum can cause extensive bleeding as well, and that's just kind of a continuous trickle of bright red blood, but the uterus is firm in midline, but you're seeing heavy bleeding. And if you can see the external location where they're bleeding, you want to put direct pressure on it. If it's an internal thing, you're going to have to call the provider and have them come in and repair it or suture it. Hematomas occur when blood collects within the tissues, so it's a hematoma within the wall of the vagina or the uterus. The person usually has very severe pain without any signs of blood loss, so there's no external bleeding, but their vital signs look like they're in hemorrhagic shock. We see this mostly with patients who have had episiotomies, forceps deliveries, or prolonged pushings, that second stage. Subinvolution of the uterus occurs with a previously normal progression, and then all of a sudden it stops or it regresses and it gets larger. The uterus is soft and large with increased bright red bleeding, so the lochia becomes rubra again, and you want to evaluate and treat the cause, and the cause is usually retained placental tissue. Retained placental tissue is the primary cause of late postpartum hemorrhage, and this can cause metritis, which is an infection, and subinvolution, and it's treated surgically with a dilation and curettage, or D&C. Remember that the drug of choice to stop bleeding is oxytocin. That's the drug that stimulates the uterus to contract, and it'll clamp down on those blood vessels and stop bleeding. Remember, during contractions, there's no blood flow to the uterus or to the placenta. So the same is true if you can, give oxytocin to the person who's bleeding. It's basically like putting a tourniquet on the uterus. It's going to clamp it down so that hopefully the person can form a clot. We don't want to give magnesium to the person who is hemorrhaging because it relaxes the uterus and it would cause further hemorrhage. Coagulation disorders could be things like DIC, amniotic fluid embolus, and DVT or thrombosis. So DIC is disseminated intravascular coagulopathy, and that occurs when there's an overuse of clotting factors, and this basically the body is breaking them down faster than it can make them, so we run out of clotting factors and then we start just hemorrhaging to death. The primary cause is placental abruption, but I also see it with HELLP syndrome, and we see it with amniotic fluid emboli and a full-blown, basically anaphylactic response to the AFE. The signs and symptoms are prolonged uncontrolled uterine bleeding, IV site and incisional site bleeding, the gums, and the bladder. We'll see petechiae and purpuric rashes on the skin, and they'll have profound signs and symptoms of shock. The treatment is IV fluids and blood to maintain a blood pressure, and then platelets and fresh frozen plasma to replace clotting factors, and oxygen therapy. You also might see them use something like TXA, which helps stabilize clots that do exist. AFE, or an amniotic fluid embolus, occurs within 24 hours of delivery. And basically the amniotic fluid or debris enters the maternal circulation, and this causes inflammation, which in turn causes vasospasm of the pulmonary vasculature, which then causes pulmonary hypotension because there's no blood going through, and that causes an elevated right ventricular pressure because the blood can't make it out of the right ventricle because all of the vasculature within the lungs are constricted. So the patient becomes hypoxic, and we start seeing capillary damage to the heart and the lungs. And then the left ventricle starts to fail because there's not enough fluid going through it to kind of pump out, and the patient develops acute respiratory distress. This also triggers an anaphylactic response, and because the blood starts to kind of pool within the lungs, the patient will form a blood clot or pulmonary embolus. So this leads to hemorrhage and DIC as kind of a secondary mechanism to the anaphylaxis. There aren't any specific risks, like there's no way to identify who would be at risk, and there's no definitive management. So, we do the best that we can with fluids and treating the overall reaction. but a person who presents with sudden onset of shortness of breath, hypotension, cyanosis, and then even seizures, cardiac arrest, and hemorrhage should be considered to have a potential amniotic fluid embolus. A thrombosis is a DVT or a blood clot in the vascular system. It can be before, during, or after pregnancy, but definitely within the postpartum period. Usually the DVT occurs first and then travels up to the lungs. Remember that during pregnancy, there's an increase in clotting factors 1, 2, 7, 9, 10, and 12, as well as fibrinogen. And this, as well as like edema and venous stasis from lack of activity, leads to the formation of a DVT and then a PE. The risk is increased in patients who have C-sections, metritis, decreased mobility, and then obesity, because obesity and the increased intra-abdominal pressure just furthers venous stasis. Signs and symptoms would be unilateral pain and swelling of an extremity, and the treatment is TEDs and SCDs for prevention, ambulation for prevention, and then heparin and warfarin for treatment. In addition to mastitis for infections, which was the inflammation or infection of the breast, we also have metritis, which is an inflammation of the endometrial or infection of the endometrial lining. And this is the most common postpartum infection. About 2% of vaginal deliveries and 15% of C-sections develop an infection. The signs and symptoms are fever, chills, pain, tachycardia, subinvolution, malaise, and a change in lochia. So it goes backwards rather than its normal progression. Treatment would be a CBC, vital signs, cultures, urinalysis, and antibiotics. And then good hand washing education, remembering to teach people that they have to wash their hands before and after using the bathroom. Cystitis is a bladder infection or a UTI. Signs and symptoms, again, would be fever, dysuria, pain, urgency, frequency, small voids. And then the risks are anesthesia, urinary retention, Foley catheter, operative vaginal delivery, neonatal macrostomia because the head causes trauma to the urethra, which then causes edema and urinary retention. The treatment for cystitis is to have the patient void, good or meticulous peri-care or hygiene, and then fluids, antibiotics, and again a CBC and a urinalysis. And the reason for the CBC is to just keep an eye on that white count. And then we always check wounds as well, just to make sure that C-sections and episiotomies don't appear infected. Last in this chapter is discussion on the psychological disorders. Postpartum blues occurs within the first few weeks. You might feel sad for a few days, but you can still care for the baby, so you're still functioning, but this is just kind of a hormonal imbalance. Postpartum depression can happen at any point in the first year, and really the hallmark sign is that the person is so depressed or despondent that they're unable to care for themselves or the baby. Signs and symptoms would be that they recognize that they're depressed, but they have a change in their mood or affect, their weight, their appetite, they lack pleasure. So they're not able to enjoy things that they used to enjoy. That's called anhedonia. Postpartum psychosis occurs when somebody who previously had bipolar disorder starts to develop severe mood swings and even command hallucinations, and starts having persistent thoughts about hurting themselves or their baby. They're in acute danger to their self and their child. Onset is as early as 3 days postpartum. Typically, they're separated from the baby and they're hospitalized, and the baby is either placed into the system or with a family member until the person can be stabilized. Paternal postnatal depression occurs related to a decrease in testosterone in the immediate postpartum period, and the person oftentimes becomes withdrawn, cynical, and irritable. And this will be continued in the next recording with chapter 15.